I'm Ben Zaitchik, professor here in the Department of Earth and Planetary Sciences at Johns Hopkins, and it's my pleasure to introduce and moderate this panel on climate and health. I'm going to briefly introduce the speakers here in the interest of time, and then I'll hand over to my co-chair, Dr. Nitish Dogra. So the speakers that we'll have lined up for you today are Dr. Purvi Patel. Dr. Patel is a senior consultant with the Indian National Center for Disease Control. In this role, she has a specific focus on the health sector response to health impacts of extreme heat and other extreme weather events in the context of climate change. Dr. Patel is a graduate of the India Epidemic Intelligence Service Program, and she's also an alumna of Johns Hopkins Bloomberg School of Public Health. After hearing from Dr. Patel, we'll be hearing from Professor Dileep Mavalankar, who is also an alumnus of Johns Hopkins, where he received his MPH and Doctor of Public Health degrees. He's also a medical doctor by training. Dr. Mavalankar worked as a faculty member in the renowned Indian Institute of Management, Ahmedabad, for 20 years. He also served as a consultant to the Maryland School of Public Health at Columbia University. His current role has been heading the Indian Institute for Public Health, Ganagar, which he has been doing for the last 12 years. Third panelist is going to be Dr. Anita Shet, who is a senior scientist in the Department of International Health here at the Johns Hopkins Bloomberg School of Public Health. Dr. Shet holds degrees from Bangalore University and the University of Minnesota, and she received her PhD from the Karolinska Institute. Dr. Shet's a pediatric infectious disease specialist with broad interest in childhood infections in low and middle income countries, and among many other activities, she leads a multi-center study on surveillance of invasive pneumococcal infections and clinical pneumonia in children, and she's currently evaluating the impact of the pneumococcal conjugate vaccine rollout in India. And finally, I'll introduce my co-chair, Dr. Nitish Dogra, who's a senior fellow at the Energy and Resources Institute, TERI. He holds an MBBS and an MD from the University of Delhi and also received a Master in Public Health degree from Johns Hopkins. Dr. Dogra has worked in the field of climate and health for over a decade with positions at INCLAN and IIHMR Delhi, in addition to his roles at TERI and time he spent as a Fulbright Nehru Fellow here in my department at Johns Hopkins. Among many accomplishments in the field that I will not have time to list, Dr. Dogra conceived of and edited the book Climate Change and Disease Dynamics in India, which offers a great compendium and collection of experts on important climate and health topics affecting India. So with that, I want to save our time and move quickly on to Dr. Dogra, who will provide some introductory remarks on the field of climate and health. So Nitish, over to you.
Thank you so much, Ben. It's great to be on a panel with you and such eminent speakers from this field. So I'll just like to sum up and give a sort of summary of the history of this field in the Indian context, very brief. My own personal journey in the field of climate and health began in 2007, about 15 years ago, right here in TERI. And at that stage, there were literally a handful of projects, mostly funded by the Indian Council of Medical Research. And they were examining upstream areas like the impact of climate change on malaria or of UV on eye health. Of course, these sort of projects continue to be important, as we will be hearing from Dr. Anita Shet. But the experts in the field were very few, although even then we had experts like Professor Rais Akhtar, who represented the health sector from India when the IPCC was awarded the Nobel Prize in 2007. But from 2013, the Department of Science and Technology, or DST, supported this area in a big way, funding almost 50 projects over the next 8 years or so, and also ensured a national research network of institutions. Also from 2015 up to recently, the National Institutes of Health, the United States, has invested in the largest systematic capacity building initiative for this field in the country, termed Understanding Climate and Health Associations in India, or UCHAI. And it has an advisory committee of national experts which guide the work. Alongside the DST initiative, with the expansion of the Prime Minister's National Action Plan for Climate Change to 12 missions, including health, the foundation of the National Plan for Climate Change and Human Health was laid. Curiously, the person at the helm of affairs was then Joint Secretary Public Health in the Union Health Ministry, Dr. Rajendra Shukla, who also happens to be a DRPH from the School of Public Health. Today, the national program is truly countrywide with 16 centers of excellence guiding the work here. And you'll be hearing from our alumna, Dr. Purvi Patel, about the program. And she also serves as a senior consultant here. You would also be hearing from Professor Dileep Mavalankar, our accomplished senior alumnus from the School of Public Health, on how the response to the heat crisis is being operationalized in Ahmedabad. And I must emphasize here that this is cited as a model, not only for India, but the entire world. So with that introduction, I would request the first panelist to make the presentation. Thank you so much.
Thank you, first of all, to Johns Hopkins Gupta Kalinsky India Institute for inviting me. I'm very privileged to be among the mentors that I had in Hopkins and also in India. So I will be taking you through India's national program on climate change and human health. So as Dr. Nitish already mentioned, just a minute, the slide is not moving. Okay. So it is one of the mission that was introduced in 2015 under Prime Minister's Climate Council, and National Center for Disease Control was the nodal agency that received the program under Ministry of Health and Family Welfare. And so after some consultation, countrywide, consultations and expert group meetings, the program was drafted and launched in 2019 with the goal to reduce injuries, mortality, morbidity, and health vulnerability to climate variability and extreme weather events. There are 5 key objectives: creating general awareness, capacity building of healthcare workforce, strengthen healthcare sector preparedness, and all the 3 key objectives pass through central to state to district to health facilities and to community level, as all the health programs, most of the health programs in India do that they reach through the community through various levels of administration. And the component 4 and 5, which is collaborative partnership and research with ICMR, which is equivalent to NIH in US, is mainly restricted to central component. So if I show you the organizational framework, you can see from top to bottom. At the center, we have headquarters of NPCCH in National Center for Disease Control, where we collaborate with centers of excellence. We have 16 to 17 centers of excellence helping us technically to design training modules and conduct trainings. We also coordinate with other ministries, mainly Ministry of Environment, Forest, Climate Change, and other programs, other health programs. Also other government partners, civil society organizations, and international agencies to mainly get technical assistance and implementation support. From here, we go to state level. We have state nodal officers identified in all the 36 states of India who are taking in charge of different activities in the program. To support them, there is governing body and multi-sectoral task force. As the climate change and health area warrants multiple coordination, the task force is tasked to review the guidelines and documents at the state level and pass state action plan on climate change and health, which can be implemented through our nodal officers in that state. And similarly, at the districts, we have district environment health cell, where district nodal officer is in charge, looking after the activity, and to support them, there is a task force and other, other staff who help in daily activities. So we have identified some climate-sensitive health issues to work on. On the left side, you can see air pollution-related diseases and heat-related illnesses, which were focused very fast because they are the biggest challenges in India. But we have gradually expanded to working on green and climate-resilient infrastructure, vector-borne diseases, extreme weather events, wash and waterborne diseases, and we are slowly working in allergic, cardiopulmonary, nutrition-related diseases, food security, vulnerability assessment, mental health, coastal climate, and hill region illnesses. To support our activities and implementation in this, we have, as I said, Center of Excellencies, and also existing health programs, which are mainly looking at host and agent aspects and lacking environmental aspects. So our main task is to work with them and integrate with the environmental parameters and see track them. So just to showcase what activities are being done at different level, you can see here at in general awareness, we have health facilities conducting IC on heat in Delhi on the left side. Then there is a vulnerable population which is also focused. You can see that heat-related illness training is being conducted in traffic workers. On the right side, on the topmost, you can see the IEC, which is played in Ahmedabad under the action plan, where they show temperature-based, implications and health prevention aspects as video graphics on the TV and in the visuals. And then you can also see some newspaper cuttings and other activities that recently had also done in international days on clean air for blue skies. So we use some international days to energize the healthcare workforce to do activity, but routinely also we do many activities which I will show you next. In terms of capacity building of healthcare workforce, when we have training modules and everything, we pass the training to state nodal officers and district nodal officers, and then they conduct the block level training, community health worker training. Those kind of trainings are done. At headquarters, we also have webinars to update latest research on relevant aspects. We also take our nodal officers at the field visits. We have gone to Kerala, to Gujarat, and currently one is going on in Raipur on air pollution. So that will enrich their experience and exchange of learnings across the states happen. The national workshop is also there, where we have a symposia and a talk and further sharing of best practices and what can be done in particular area in their states. And we also arrange review meetings to see the progress of our program every year. To strengthen health sector preparedness, particularly we have these many measures. So operationally, we have national health adaptation plans. In all the diseases that I mentioned, we have some of them already published. You can see in the bottom, there is one on air pollution related diseases and one on the health related illnesses, heat related illnesses, and others are in the making and they should be out soon. We have also directed states to make state level action plans. So for all the vulnerability that state experiences, they make action plans. Some of them are already approved and being launched. And similarly, at district level, action plans are being made. At central level, we also issue advisories for health sector preparedness for particular, extreme weather event or particular illness at the time of the season. We also try to issue early warning of extreme weather in coordination with Central Pollution Control Board or Indian Meteorological Department. So we try to integrate health sector to their early warning. So our health facilities and officers receive early warning for preparedness. We also trying to monitor, vector-borne diseases with the parameters of weather, so like EWARs, which will intimate us of outbreak possibilities in dengue. So this is in the process, and we already have surveillance of air pollution and heat-related illnesses, which is expanding countrywide. And we have done some vulnerability assessment in some of the states. And structurally, the major component is green and climate resilient healthcare infrastructure, where we are currently working on energy efficiency, renewable energy like solarization, rainwater harvesting, and also prescribing full roof flood resilient measures and other things for new buildings and retrofitting. So all these things are being made. You can see on the right, bottom right, some solutions in Chhattisgarh, flood resilient PSC in Kerala. So states and districts can also take their own initiative. So many states have progressed and done many states have done solarization in their PSC and CSC. So they also have their own task and they do activities by them. So the challenges are there. Technical expertise, having them all in one place and getting all the needed experience, that is challenging. Translating research into policy, having awareness among stakeholders, multi-sector coordination, real-time integrated tracking of health and meteorological indicators, and obviously resource constraints. So these are the big ones that I think of, and I'm looking forward to the discussion. Thank you.
Thank you so much, Dr. Patel. I think now we'll move on to Dr. Mavalankar. Please go ahead.
Yeah. Thank you very much. Let me share my presentation. I'm really delighted to be invited to my alma mater, where I studied in the 80s with my Master of Public Health and Doctorate in Public Health. So I'm delighted to be invited to the Hopkins Gupta Klinsky India Institute. What I'm going to present in next 7 minutes is heat action planning in India, example from my city of Ahmedabad. As you know, India is very hot, and in the summer, large parts of India, Pakistan become very hot. The temperatures are upwards of 100 degrees Fahrenheit, sometimes more than 110 degrees Fahrenheit, which is the dark maroon color which you see across from Pakistan to India. So many people are used to very hot temperatures. But when we first started looking at what happens to all-cause mortality in the city of Ahmedabad, Ahmedabad had a major heat wave in 2010. And this is a crowded graph. I will explain. There are 4 variables put on the graph. The average temperature every day in the month of May, average of 2009 and 2011, 1 year before the heat wave and 1 year after the heat wave. And the red line on the top is the temperature of 2010 May. On 21st of May 2010, you see the temperature reached 47 degrees centigrade in Ahmedabad, which is normally at around 41 to 43 degrees average. Now, on that day, when we compiled the data from the Registrar of Birth and Death, all-cause mortality in Ahmedabad, given its 5 million population, is roughly about 100 people die every day of all causes. In 2010, during the heat wave, which started on 19th roughly of May to 27th, you will see the all-cause mortality, which is the brown color bars, went up to 310 deaths on 21st May 2010, and then it came down. So the whole heat wave period of 1 week had additional 800 deaths in just 1 week, and the month of May of 2010 had additional about 1,300 deaths in the city of 5 million people. And this such high increase in all-cause mortality was never recorded in any South Asian city before we did our work of this in 2013. And this woke up the city to the possibility of high excess mortality during the heat waves. Heat waves have been coming in Ahmedabad for almost 100 years, where we have temperature records. But this type of correlation with mortality was only done when we compiled this data. So this is not very great modeling, but very simple public health correlation of all-cause mortality with the daily temperatures of Ahmedabad city. It is very similar to the heat wave of 1995 in Chicago and 2003 heat waves in Europe, and we learned from that. Starting, we also analyzed last 15 years of data, then took the maximum temperature and daily deaths in the summer of 3 months in Ahmedabad and drew a best fitting line which shows you that at 41 degrees, the temperature of 41 degrees maximum temperature, mortality starts rising. At 43 degrees, it further rises, and 45 degrees, it rises further. So these were used as the cutoffs for alert system, which was developed by the city along with us and the international experience brought by the National Resources Defense Council. So this helped develop the Ahmedabad Heat Action Plan in 2013, which looked like that. And it had learnings from the other countries. It's nothing very dramatically new, but first time a threshold-based heat action plan for a city was being developed. It had 4 major components: early warning system and interagency coordination, public awareness and community outreach, capacity building of medical and paramedical systems, and reduction in heat exposure and promoting adaptive measures. The first was early warning system. Initially, we got early warnings from Georgia Tech in US for first 3 years, and later on from 2016, the India Meteorology Department started a 5-day early warning system in almost 100 cities in India. And now they are doing it for almost 1,000 cities in India. The nodal officer of the city which is a deputy health officer, received this early warning every evening and then alerted various departments of the city government, the state government, and the media and public through the interagency response plan, which was developed. We also, with the city, created a lot of awareness that heat kills on a large scale. And this data, when we presented, everybody was shocked that in 1 week, 800 additional deaths could happen. We had posters, various training programs for people exposed to heat, various informal and formal workers, public announcements, electronic display boards, and later on using social media, creating public awareness about heat and early warning system. We also organized several workshops of the medical fraternity within the city of how to manage the cases of heat-related illnesses to save from death, so reduce mortality. We also work with the city and the NGOs to develop cooling centers in the public parks and other places, as well as free water distribution points in the city, so people who are working in the afternoons and don't have access to water could receive free drinking water at various places. And many other measures were taken. Later in 2016 onwards, we started along with the state government, national government, and the city government a plan for cool roofing. This is a picture where one of the slum dwellers is painting her roof of the shanty with white color. And there were other modified roofing materials which were also used to reduce heat ingress in the poorer areas and vulnerable areas. The impact of heat action plan was estimated to see that there was reduction in all-cause mortality and heat stroke cases and deaths. And the initial estimate was made, which is published in 2018, that every year about 1,200 deaths were prevented because of this additional heat action plan in the city. This is the heat stroke cases and deaths reported from 5 sentinel major hospitals of the city before heat action plan, which is 2010, and in 2014, 15, 16, 17, and 18 following the heat action plan. And even though the temperatures were quite high in 16 and 18, the mortality and cases were substantially low. We also analyzed all-cause mortality using relative risk of mortality, correlating it with the daily maximum temperature. And the graph clearly shows the red graph is before the heat action plan, and the black graph line is after the heat action plan. So the mortality beyond 44 degrees centigrade has dipped after the implementation of the heat action plan. Learning from this plan implementation and its success, the National Disaster Management Authority recognized it as a model plan, and through them it was scaled up in 100 districts and many states across India. This plan was also awarded the Earth Care JSW Times of India Environmental Award in 2018. And we have also produced substantial materials as well as research papers out of this. Finally, I want to thank the Institute to invite me, and I want to recognize the work is a joint work between the city government of Ahmedabad, which symbol is in the middle, NRDC USA, CDKN, University of Washington, Mount Sinai Medical School in New York, the India Meteorology Department, and the 108 emergency ambulance system. What it basically showed that one city using an academic institution and international partnership can work out their local thresholds using the raw all-cause mortality and set up a early warning system which can help reduce the mortality and morbidity due to heat waves. And this is just the beginning of the climate change. And unless we do this, many more people may get affected. But we have shown that it is possible to reduce the mortality by 30 to 40% using very simple steps. Thank you very much.
Thank you so much, Professor Mavalankar. Really inspiring work. With that, we'll move on to our final panelist, Dr. Anita Shet. So Anita, why don't you take it away?
Hello, everyone. I hope you can hear me. So thank you for this session, for organizing this panel discussion. So as a pediatrician, I have to begin by talking about children. So there are very few global movements that have been begun by children. So back in August 2018, there was a 15-year-old schoolgirl in Sweden who began a school strike for climate. We've all heard of Greta Thunberg. So in the beginning, she was alone, but now this is an international movement. And because of this significant beginning, that it was started by a child, I would like to focus on children's perspectives with regard to this topic. And you'll see why in a minute. Scientists from different disciplines have been working using high resolution population data and geographical data, and they put together these staggering numbers. 1 billion children in the world today, you can see here on the slide, are at high risk of the impact of the climate crisis. And the numbers of children exposed to different climate hazards, as shown on the right side, you can see are also staggering in its size. And you can surmise that many of these children have overlapping risks, which increases their vulnerabilities. So if we look at the effects of climate change in children, so the effects are not felt equally, right? Children will bear the greatest burden, and even amongst them, the most vulnerable children bear the greatest burden. So if we look at the direct and the indirect health effects, there are extreme weather events such as cyclones and fires that threaten their lives and destroy critical infrastructure like their homes and families and schools. Floods compromise water and sanitation facilities, and droughts bring about crop failures and rising food prices, which mean that there is food insecurity and these nutritional deprivations that can have lifelong impacts. And then there is air pollution, which have devastating health effects, allergies and effects on the respiratory systems. Now, the indirect effects shown on the right, there's actually not a very clear demarcation between direct and indirect, but the indirect effects are vast, and there are only a few I've listed here, including health access barriers, exposure to violence, but infections by large have a big chunk of the work that has been done to understand these effects. And if we look deeper, we see that over 90% of the burden of disease attributable to climate change is borne by children under the age of 5. So if we look at how a little deeper into infections and climate change and how they interact, here is a comprehensive report that I found. This was published very recently in Nature Climate Change. And this team reviewed almost 80,000 papers, books, and reports. And after rigorous study and intense analysis, they've created these interactive pathways to understand the relationships between these different factors. And it's a fun thing to explore. And I put the link there in the slide. And you can take a look at how they interact. And basically, they've looked at 10 climate hazards, such as warming, floods, rainfall, etc., shown on the left side of this figure, and the mode of transmission on the right side. And the colors have significance as well. Darker the color, greater the numbers. And the pathogen groups are listed on the right side. So basically, they found that climate change brings pathogens and humans closer together. Of course, we know that. And there are plenty of examples as well that we've studied. Examples like increase in temperature and rainfall that have expanded the range of mosquitoes contributing to increased outbreaks of dengue fever, chikungunya, and malaria that we've been seeing over the last few decades. And floods in different places that are often followed by outbreaks of cholera and typhoid. Again, children are disproportionately affected in these conditions. So in summary, this team found that the climate hazards can exacerbate 218 diseases. And this would be 58% of the known and classified infections by the Center for Disease Control, CDC. So this is over half of known human pathogens. And these numbers rise to even greater numbers, 277, when you include non-transmissible conditions, which are also affected by climate hazards, such as asthma and poisonous snake bites and insect bites. So imagine that climate change can worsen more than 200 known diseases. And it's actually hard to measure the effect on populations, and particularly children. But here's one approach which was developed by a team at UNICEF, and it's called the Children's Climate Risk Index, CCRI. So this provides a comprehensive view of children's exposure and vulnerability to the impacts of climate change. The index also ranks countries based on how vulnerable the children living in those countries are to the environmental stresses and these extreme weather events. And here I've just pasted the first page of that list. This is a list of 163 countries. And you can see that India is 26th on that list. So clearly there's a lot that has to be done. And it's really gratifying to hear all the work that's been going on so far. And there are folk doing incredible work in India on small scales as well as large scales, as you've heard just now from Dr. Purvi Patel and from Professor Mavalankar. So here's one of the things, the work that I want to highlight from our partner, the Child in Need Institute. They work in the Sundarban area in West Bengal. And they've spoken recently in the past few months to over 1,000 children, so 164 children aged between 9 and 18 years who live in the Sundarbans. And they were asked what their main concerns were with regard to climate change. And you can see there are different answers. I've just put a few there. So many of them are, of course, concerned about their homes being submerged and having no place to live, and schools being closed and missing classes, and diseases increasing. So this is just a glimpse of the work. But the idea here is to highlight and elevate these children's voices, because many times they may have solutions that the adults may not have thought of. So that's one of the things that I wanted to highlight in this talk. So you've heard about the different steps that are being taken for mitigation and adaptation. It's really an ongoing work in progress. So one of the approaches that I would like to think about is, how can we make children a focus of these environmental strategies and empower them to be agents of change? And also, of course, at the same time, protect them from the negative effects. So you can see that there is this vicious cycle of increasing vulnerabilities that children are caught in the middle of. And of course, this increases their risk, and they're all related. All the different vulnerabilities are related to each other. But we've also heard how strengthening basic systems can actually protect children and families against the effects of climate change. And basically they fall into these categories of health, so primary health care and WASH, the water, sanitation, hygiene that you just heard about, education and social protection. So interrupting that vicious cycle at all of these points actually can go a long way. And often we think, we are just individuals or institutions. This is the work of governments and world agencies, but there are things that we could do at our level. I put that in a box there on the left side, and that is include climate change and health and the other distal aspects in our research. And many are already doing that. And then bring in this climate conversation into our teaching within the institutions. And of course, public action and advocacy are what we do as public health people. And personally, too, there are things that we could do, lead by example to bring this whole aspect to the forefront. So I'd like to stop and say thank you, and back to you. Thanks to the moderators.
Great. Thank you so much, Dr. Shet, and thanks to all of our panelists. We have just a few minutes here for questions. If you have any, please type them into the Q&A, and I'm sure we can also follow up with answers if there's not time to address them. I would like to open with one question, perhaps. Nitish, do you have a question already lined up, or can I go ahead?
Yeah, please go ahead.
Okay, sorry. I promised Nitish you had first question, but I'm eager to get asked because such inspiring work. I'd like to focus on heat as an example, but it doesn't have to just be heat. And one thing that I know we struggle with is the contrast between these acute responses, right? And Dr. Patel and Dr. Mavalankar spoke to the really effective immediate actions and early warning and preparedness that's been able to reduce mortality. On one hand, we have those acute responses. On the other hand, we have the longer term adaptations, kind of the anticipatory adaptations, such as the white roofs that Dr. Mavalankar referred to. And I'm curious if you could speak a little bit to all of our panelists to this challenge of long-term adaptation and what role the health sector and what role health experts are playing in trying to really roll out solutions like white roofs, but perhaps also even more ambitious and challenging large-scale solutions that we might need in the long run. Is there a role for the health experts and health sector to play there in order to motivate society towards these kinds of large-scale changes?
Can I start?
Please.
Yeah.
Please.
First is, I think the cool roof is just one example. Cool buildings, even solar, which is reducing the roof temperature as well as reducing the electricity demand. So we have recently worked on a project where we estimated how can we reduce the electricity demand as well as air pollution in 2030 in Ahmedabad city using cool roofs and solar panels. And we have estimated that almost 16,000 deaths could be reduced annually if substantial use of this. So I think those types of technologies are there. Second is we have to prepare our health systems better, because as of now, health systems really haven't woken up to the heat-related and other long-term measures. Third is our data systems in India are still very primitive. People were talking of this modeling in the previous and global satellites, and we can't even figure out a cause of death or even record a person who dies. We know what happened in COVID. We have so many deaths we are not recording properly. So I think some of the basics of public health, which I learned in 1980s in Hopkins, are still very, very primitive. So long-term measures include preparing our basics of public health. Third, within India, we don't have anywhere environmental health as a division, department, people trained in environmental health. People are trained in public health and people are trained in environment, but there are no places where there is environmental health training. So no city generally employs an environmental health expert. Of course, statisticians are missing everywhere from national to the local level. So there are lots of public health gaps and health system gaps, which will affect the long-term effort. The last is, I think, communication to the people, saying that this is one of the hazards and people have to understand the iceberg nature of the mortality. That what you see 1 or 2 or 10 deaths appearing in the newspaper of somebody standing in the road or policeman is just the tip of the iceberg. Most of the deaths are in old and comorbid people and in neonates, which is not really understood. So I think protecting them in a place where air conditioning is very, very low, other heating or cooling devices, for example, there have been studies saying fan after certain degrees of temperature outside will actually be harmful than helpful. So I think those type, I have been promoting that the physiology departments of medical colleges have to take up studies of heat physiology, very little heat physiology work outside of military is happening, and maybe 1 or 2 national institutes may be doing heat physiology. So how much is the maximum temperature which we can, at least even acclimatized Indians can tolerate, with comorbidity, without comorbidity? That would be the kind of work. Thank you.
Great. Thank you so much for that rich answer. I'm told we have just a couple of minutes, and so maybe if I could just ask Dr. Patel or Dr. Shet if you'd like to comment
Yes, sir.
on that question. Yes, go ahead, Dr. Patel.
Yeah, I would like to answer. So I have more programmatic perspective, and I see it like long-term impact in 3 different ways. So we have community phase, health facility phase, and stakeholders. And so if we think that way, one of the things that we are trying to achieve is a behavioral change through IEC, and that should, get us to have behavioral change and sort of long-term impact through that activity. In terms of health facilities, long-term impact in health sector, we are trying to achieve like infrastructural changes that can, keep them working in terms during the disaster, so that we are seeing. We are in the initial phase, but we are trying to work out with the different partners and agencies to have some guidelines on the infrastructural part of the health facilities. For that, and then other is the important is the health data that we are gathering as part of surveillance. So monitoring that with meteorological parameters should awaken, and inform stakeholders for more and more action on the ground for mitigation rather than more than adaptation. So that's the primary goal. So I think those 3 things in the program health sector should help more long-term activities.
Anita, please.
There's a lot been said, so I don't know how much I can add. But one thing to think about is to bring this whole concept into our educational systems. And I don't know how much of that is being taught at schools, because that is where the whole behavior change aspect can take place. So once again, focus on children. Thank you.
Yes, absolutely. I think that's a great closing thought. Nitish, would you like to make any closing remark before we hand back to the organizers?
So the only part that I want to emphasize is that, some of the very critical aspects that affect India, like malnutrition, diarrhea, besides vector-borne disease and heat and air pollution, these are the, for example, these are the very, very important areas which somehow don't get the proportionate emphasis in relation to climate change. So these are a major disease burden, as also mentioned by Professor Dr. Anita Shet. So that's where we really need to look at to prioritize and not chase, something outcomes which have very little relevance and burden of disease terms.
Great, thank you. Well, it's exciting work to be done, I think, by the group assembled here and the broader network through GKII. So Bob and Nancy, back to you to close the program.
Thank you all. So this is Bob Bollinger, and on behalf of the Johns Hopkins Gupta Clincy Institute, I'd like to thank all of the panelists, our keynote speakers, our co-chairs, and all the participants for a terrific session, a challenging and an interesting and important discussion for all the panelists. And thank you very much. Particularly like to thank Tanya Chatterjee and Coulter Billings for their help in organizing this. Nancy?
No, absolutely. And I just add my thanks to yours for these really interesting talks and all of this. There's so many exciting ideas that were shared today. And it's certainly my hope that this is going to stimulate future collaborations to address some of this really critical, these critical challenges. So thank you all. And thanks to the participants who were here today.
Thank you. Thank you.
Thank you all.
Thank you, everybody. I'm going to go ahead and end the Zoom call now.
Well,
All right. Bye-bye.